What did you think of that last session? I thought it was interesting how the speaker talked about asthma biologics and their mechanisms of action.
I agree. I'm hearing about that more and more. The inflammatory response in asthma can be complicated, and it isn't uniform across different types of asthma. Understanding a biologic's mechanism of action can be important, and it can impact how we treat our patients. What do you think?
Welcome to Dialogues Dimensionalized, expert perspectives on allergic asthma. Sponsored by XOLAIR, omalizumab.
You bring up a good point. For me, I think about the underlying drivers of a patient's disease. Those factors help me consider different treatment options.
Makes sense. Come to think of it, I recently had a similar discussion with some colleagues about patients with moderate to severe asthma who have an underlying allergic phenotype.
So tell me more about your discussion on allergic phenotype patients.
Well, first, I noted that we always have to remember that asthma has more than one phenotype, and that the mechanisms behind what drives each phenotype are unique.
Great point. I've been thinking about that a lot for my patients who are no longer controlled on inhalers and who I need to escalate to a biologic. With so many options out now, I always start by looking at my patient's positive test to allergens on a radioallergosorbent or skin prick test, since about 60% of asthma is allergic.
Makes sense. About 60% is a pretty high percentage. So what do you do for those patients?
Well, if they test positive for an aeroallergen, XOLAIR is my first consideration for appropriate moderate to severe allergic asthma patients age 6 and older whose symptoms are uncontrolled on inhaled corticosteroid treatment. But of course, I always keep in mind that XOLAIR has a box warning for anaphylaxis, which can be life-threatening, and that it is contraindicated for some patients, like those with a severe hypersensitivity reaction to XOLAIR or to any of its ingredients.
I take a similar approach when it comes to biologics. If allergies are triggering the asthma, I know that IgE is a key driver of that response, and it only takes a small amount of IgE, as low as 30 international units per milliliter, to trigger it. My colleagues and I talked about why IgE matters.
What did you say?
Well, IgE plays a key role in the allergic response for asthma patients with allergies. As you can see in this illustration, the production and release of IgE also has consequences for other parts of the inflammatory cascade, like the elevation of pro-inflammatory interleukin levels and eosinophil counts. XOLAIR has been shown to reduce the inflammatory mediators interleukin-4, interleukin-5, and interleukin-13, along with blood and tissue eosinophils.
That's right. Based on preclinical models, XOLAIR inhibits the binding of IgE to high-affinity receptors on dendritic cells, basophils, and mast cells.
And by keeping IgE from binding to these high-affinity receptors, XOLAIR induces receptor downregulation, limits mast cell degranulation, reduces eosinophils, and minimizes the release of inflammatory mediators in the early and late phase of the allergic response.
An important takeaway is that the allergic response is complicated and non-linear, and IgE plays a role throughout. This is why it's imperative that we test for allergic triggers in our patients.
Definitely.
What else did you cover?
We talked about the pharmacodynamics of XOLAIR, which result in a reduction in the serum-free IgE levels within the first hour of administration.
That's really interesting. I've also read that XOLAIR binds directly to IgE and decreases serum-free IgE levels by more than 96% when dosed according to the package insert.
That's correct. I also left the discussion with this clinical pearl to keep in mind. Patients' specific serum IgE levels do not correlate with the intensity of their allergic reactions. And with XOLAIR, serum IgE, along with body weight, is used only to determine dosing. Understanding what's specifically triggering IgE release has to be identified through allergy testing.
I've heard some allergists say that IgE levels have to be high in order for the asthma to be considered allergic. But as you mentioned, even small amounts of IgE can trigger an allergic response. And it only takes sensitivity to one allergen to drive uncontrolled disease in susceptible patients.
Good point. It's so important to consider these aspects of the mechanism of disease when treating asthma patients with allergies.
It sure is. Sounds like you had a great discussion.
I'd like to think so. Ready for the next presentation?
Sure, after you.
Indication: XOLAIR, omalizumab, is indicated for adults and pediatric patients 6 years of age and older with moderate to severe persistent asthma who have a positive skin test or in vitro reactivity to a perennial aeroallergen and whose symptoms are inadequately controlled with inhaled corticosteroids. Limitations of use: XOLAIR is not indicated for the relief of acute bronchospasm or status asthmaticus. Important safety information. Warning: anaphylaxis. Anaphylaxis presenting as bronchospasm, hypotension, syncope, urticaria, and/or angioedema of the throat or tongue has been reported to occur after administration of XOLAIR. Anaphylaxis has occurred as early as after the first dose of XOLAIR, but also has occurred beyond 1 year after beginning regularly administered treatment. Because of the risk of anaphylaxis, initiate XOLAIR therapy in a healthcare setting and closely observe patients for an appropriate period of time after XOLAIR administration. Healthcare providers administering XOLAIR should be prepared to manage anaphylaxis, which can be life-threatening. Inform patients of the signs and symptoms of anaphylaxis and instruct them to seek immediate medical care should symptoms occur. Selection of patients for self-administration of XOLAIR should be based on criteria to mitigate risk from anaphylaxis. Contraindications: XOLAIR is contraindicated in patients with a severe hypersensitivity reaction to XOLAIR or to any ingredient of XOLAIR. Warnings and precautions. Anaphylaxis. Anaphylaxis has been reported to occur after administration of XOLAIR in pre-marketing clinical trials and in post-marketing spontaneous reports. In pre-marketing clinical trials in patients with asthma, anaphylaxis was reported in 3 of 3,507 0.1% patients. Anaphylaxis occurred with the first dose of XOLAIR in 2 patients and with the 4th dose in 1 patient. The time to onset of anaphylaxis was 90 minutes after administration in 2 patients and 2 hours after administration in 1 patient. A case control study in asthma patients showed that among XOLAIR users, patients with a history of anaphylaxis to foods, medications, or other causes were at increased risk of anaphylaxis associated with XOLAIR compared to those with no prior history of anaphylaxis. In post-marketing spontaneous reports, the frequency of anaphylaxis attributed to XOLAIR use was estimated to be at least 0.2% of patients based on an estimated exposure of about 57,300 patients from June 2003 through December 2006. Approximately 60% to 70% of anaphylaxis cases have been reported to occur within the first 3 doses of XOLAIR, with additional cases occurring sporadically beyond the 3rd dose. Initiate XOLAIR only in a healthcare setting equipped to manage anaphylaxis, which can be life-threatening. Observe patients closely for an appropriate period of time after administration of XOLAIR, taking into account the time to onset of anaphylaxis seen in pre-marketing clinical trials and post-marketing spontaneous reports. Inform patients of the signs and symptoms of anaphylaxis and instruct them to seek immediate medical care should signs or symptoms occur. Once XOLAIR therapy has been established, administration of XOLAIR pre-filled syringe or autoinjector outside of a healthcare setting by a patient or a caregiver may be appropriate for selected patients. Patient selection, determined by the healthcare provider in consultation with the patient, should take into account the pattern of anaphylaxis events seen in pre-marketing clinical trials and post-marketing spontaneous reports, as well as individual patient risk factors, e.g. prior history of anaphylaxis, ability to recognize signs and symptoms of anaphylaxis, and ability to perform subcutaneous injections with XOLAIR pre-filled syringe or autoinjector with proper technique, according to the prescribed dosing regimen and instructions for use. Discontinue XOLAIR in patients who experience a severe hypersensitivity reaction. Malignancy. Malignant neoplasms were observed in 20 of 4,127, 0.5%, XOLAIR-treated patients compared with 5 of 2,236, 0.2%, control patients in clinical studies of adults and adolescents greater than or equal to 12 years of age with asthma and other allergic disorders. The observed malignancies in XOLAIR-treated patients were a variety of types, with breast, non-melanoma skin, prostate, melanoma, and parotid occurring more than once, and 5 other types occurring once each. The majority of patients were observed for less than 1 year. The impact of longer exposure to XOLAIR or use in patients at higher risk for malignancy, e.g. elderly, current smokers, is not known. A subsequent 5-year observational study of 5,007 XOLAIR-treated and 2,829 non-XOLAIR treated adolescent and adult patients with moderate to severe persistent asthma and a positive skin test reaction or in vitro reactivity to a perennial aeroallergen found that the incident rates of primary malignancies per 1,000 patient years were similar in both groups, 12.3 versus 13.0 respectively. Study limitations, which include the observational study design, the bias introduced by allowing enrollment of patients previously exposed to XOLAIR, 88%, enrollment of patients, 56%, while a history of cancer or a premalignant condition were study exclusion criteria, and the high study discontinuation rate, 44%, preclude definitively ruling out a malignancy risk with XOLAIR. Acute asthma symptoms and deteriorating disease. XOLAIR has not been shown to alleviate asthma exacerbations acutely. Do not use XOLAIR to treat acute bronchospasm or status asthmaticus. Patients should seek medical advice if their asthma remains uncontrolled or worsens after initiation of treatment with XOLAIR. Corticosteroid reduction. Do not discontinue systemic or inhaled corticosteroids abruptly upon initiation of XOLAIR therapy for asthma. Decrease corticosteroids gradually under the direct supervision of a physician. Eosinophilic conditions. In rare cases, patients with asthma on therapy with XOLAIR may present with serious systemic eosinophilia, sometimes presenting with clinical features of vasculitis consistent with Churg-Strauss syndrome. These events usually, but not always, have been associated with the reduction of oral corticosteroid therapy. Physicians should be alert to eosinophilia, vasculitic rash, worsening pulmonary symptoms, cardiac complications, and/or neuropathy presenting in their patients. A causal association between XOLAIR and these underlying conditions has not been established. Fever, arthralgia, and rash. In post-approval use, some patients have experienced a constellation of signs and symptoms, including arthritis, arthralgia, rash, fever, and lymphadenopathy, with an onset 1 to 5 days after the first or subsequent injections of XOLAIR. These signs and symptoms have recurred after additional doses in some patients. Physicians should stop XOLAIR if a patient develops this constellation of signs and symptoms. Parasitic Helminth infection. Monitor patients at high risk of GO-Helminth infection while on XOLAIR therapy. Insufficient data are available to determine the length of monitoring required for GO-Helminth infections after stopping XOLAIR treatment. Laboratory tests. Due to formation of XOLAIR IgE complexes, serum total IgE levels increase following administration of XOLAIR and may remain elevated for up to 1 year following discontinuation of XOLAIR. Do not use serum total IgE levels obtained less than 1 year following discontinuation to reassess the dosing regimen for asthma patients because these levels may not reflect steady-state free IgE levels. Potential medication error related to emergency treatment of anaphylaxis. XOLAIR should not be used for the emergency treatment of allergic reactions, including anaphylaxis. In studies to simulate use, some patients and caregivers did not understand that XOLAIR is not intended for the emergency treatment of allergic reactions, including anaphylaxis. The safety and effectiveness of XOLAIR for emergency treatment of allergic reactions, including anaphylaxis, have not been established. Instruct patients that XOLAIR is for maintenance use to reduce allergic reactions, including anaphylaxis, while avoiding food allergens. Adverse reactions. Asthma. In patients greater than or equal to 12 years of age, the most common adverse reactions, greater than or equal to 1% more frequent in XOLAIR-treated patients, were arthralgia, 8%, pain, general, 7%, leg pain, 4%, fatigue, 3%, dizziness, 3%, fracture, 2%, arm pain, 2%, pruritus, 2%, dermatitis, 2%, and earache, 2%. In pediatric patients 6 to less than 12 years of age, the most commonly observed adverse reactions, greater than or equal to 3% more frequent in XOLAIR-treated pediatric patients, were nasopharyngitis, headache, pyrexia, upper abdominal pain, pharyngitis streptococcal, otitis media, viral gastroenteritis, arthropod bite, and epistaxis. Injection site reactions. In adults and adolescents with asthma, injection site reactions of any severity occurred at a rate of 45% in XOLAIR-treated patients, compared with 43% in placebo-treated patients. Severe injection site reactions occurred more frequently in XOLAIR-treated patients compared with patients in the placebo group, 12% versus 9% respectively. The types of injection site reactions in asthma studies included bruising, redness, warmth, burning, stinging, itching, hive formation, pain, indurations, mass, and inflammation. Injection site reactions in healthy adults. In an open-label trial in healthy adults, in which the 300 mg 2 ml autoinjector was compared to the 300 mg 2 ml pre-filled syringe, injection site reactions, e.g., induration, pain, erythema, hemorrhage, swelling, discomfort, bruising, hypoesthesia, edema, pruritus, were observed in 24%, 16 out of 66, of subjects treated with the autoinjector, compared with 14%, 9 out of 64, of subjects treated with the pre-filled syringe. Cardiovascular and cerebrovascular events from clinical studies in patients with asthma. A 5-year observational study was conducted in 5,007 XOLAIR-treated and 2,829 non-XOLAIR-treated patients greater than or equal to 12 years of age with moderate to severe persistent asthma to evaluate the long-term safety of XOLAIR, including the risk of malignancy. The results suggest a potential increased risk of serious cardiovascular and cerebrovascular events in patients treated with XOLAIR. However, the observational study design, the inclusion of patients previously exposed to XOLAIR, 88% for a mean of 8 months, baseline imbalances in cardiovascular risk factors between the treatment groups, an inability to adjust for unmeasured risk factors, and the high study discontinuation rate, 44%, limit the ability to quantify the magnitude of the risk. Pregnancy. Data with XOLAIR use in pregnant women are insufficient to inform on drug-associated risk. You may report side effects to the FDA at 800-FDA-1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888-835-2555 or Novartis Pharmaceuticals Corporation at 888-669-6682. Please see full prescribing information, including boxed warning and medication guide, for additional important safety information.